Welcome to the deep dive. Ever gotten a small cut or noticed a tiny skin tag and maybe watched a doctor or nurse handle it with this, like, surprising amount of care? Using specific tools, you might have wondered what's really going on there. Well, today, we're pulling back the curtain on the incredible complexity just beneath your skin's surface. We're doing a deep dive into the integumentary system. Yeah, your body's largest organ, the skin, plus all its bits and pieces, the accessory structures. Forget thinking of skin as just, a cover. You're about to discover the amazing detail involved in diagnosing it, fixing it, even rebuilding it. Our mission today, to unpack the world of CPT codes, current procedural terminology specifically for these integumentary procedures. Now, these aren't just numbers. They're like an invisible language guiding everything from a simple biopsy to really complex reconstructive surgery. It's all about accuracy. You get a real shortcut to understanding the kind of precision medical pros use every single day. And maybe some surprising facts along the way. Okay, let's unpack this then. The skin, it really is so much more than meets the eye, isn't it?
Oh, absolutely. And what's really fascinating here is that even procedures that seem, pretty straightforward, they demand a deep grasp of anatomy and these incredibly specific guidelines. To really get the complexity, we kind of need a quick refresher on the skin's layers, because honestly, they determine everything about how a procedure is done and, crucially, how it gets coded.
Right. So we're talking about the epidermis first, and that's the outer bit we see, our sort of first line of defense.
Exactly. Protective layer.
Then underneath that, the dermis, which is like the busy layer, connective tissue, blood vessels, hair follicles, sweat glands, gives skin its strength.
Strength and flexibility. That's where a lot of the important structures are.
And then deepest down, the subcutaneous tissue, mostly fat, connective tissue, kind of anchors the skin to whatever's below.
Precisely. Anchors it down. And don't forget those accessory structures within these layers, the hair shafts, roots, oil glands, nerve endings, hair bulbs, sweat glands. They're all part of the system. Now, here's the key thing. The depth of procedure goes into these layers and its exact location. That's not a minor detail. It fundamentally changes the intervention, the resources needed, and, well, how it's classified and coded.
So it's not just a skin procedure. It's really about which part of the skin, how deep they're going, and that changes everything.
It absolutely does. A surface scratch versus something hitting deep tissue, completely different ballgame.
Makes sense.
And you really see this distinction when we look at diagnostics like biopsies. Take fine needle aspiration, FNA.
Okay.
Here, a very fine needle aspirates material just sucks up some cells, basically. And those cells are looked at cytologically.
Logically, meaning cell by cell.
Yeah, studying individual cells. That's different from a core needle biopsy, which uses a bigger needle to get an actual chunk of tissue for histopathologic evaluation.
Histopathologic. So looking at the tissue structure.
Exactly, how the cells are arranged together.
So FNA is like looking at scattered puzzle pieces, and the core biopsy is like seeing a small section of the finished puzzle.
That's a really great way to put it, yeah. Now, a critical point with FNAs, especially for coding, is imaging guidance.
Right, like using ultrasound or CT.
Precisely. If imaging guidance is used for certain FNA codes, think 1004 to 1012 or 10021, that guidance is actually bundled into the FNA code itself.
Bundled, meaning you can't bill for it separately.
Correct. You cannot report it separately for the same lesion. And this isn't just, bureaucracy. It's designed to prevent incorrect billing, like upcoding.
Okay, that sounds like a major tripwire for coders.
It definitely can be, especially if maybe different imaging types are used for separate lesions in the same session. Then you need things like modifier 59 to show they were distinct. It gets specific.
Wow, okay, so that covers getting cells. What about when you need more tissue for diagnosis? Other biopsy types?
Right. Beyond FNAs, we have other techniques, generally under codes 11102 to 11107. The key here is they're only for diagnostic purposes getting a sample, not removing the whole thing.
Got it. Diagnostic intent.
3 main ways. First, tangential biopsy. This uses a sharp blade, maybe a shave, scoop, or curette to get epidermal tissue, maybe a bit of the dermis too. It's partial thickness.
Like taking a very thin slice off the top.
Exactly. Just enough for the pathologist to examine. Then there's the punch biopsy.
Okay, I think I've seen those tools. Little round cookie cutter things?
Sort of, yeah. It takes a full thickness, cylindrical sample, good for lesions suspected to go deeper. And interestingly, simple closure, like a single stitch, is included in that code.
Okay, included.
And finally, incisional biopsy. This uses a sharp blade, but not a punch. It's a vertical cut or wedge going deep into the dermis, sometimes even into the subcutaneous fat.
Why would you need to go that deep?
Well, for conditions like paniculitis, inflammation of that deep fat layer, you need a good sample. And again, simple closure is bundled in.
It really is like choosing the right tool for the job, isn't it?
Yeah,
Each one designed for a specific depth and purpose.
precisely.
So what if the doctor needs multiple samples, maybe from different spots? How does the coding handle that level of detail?
Ugh, good question. It gets even more specific there. If you do multiple biopsies using the same technique, say 3 punch biopsies on separate lesions, you use the main punch code, then add-on codes for the second and third punches.
Okay, same technique. Use add-ons.
But if you use different techniques for separate lesions, maybe one tangential biopsy and one punch biopsy, you pick the right primary code for the first technique and then use an add-on code representing the other technique for the second biopsy.
Wow. So you really have to track technique and lesion.
Absolutely. Because, the work involved, the resources, the diagnostic information you get, it all varies. It just sells. A thin slice, a full thickness core, the coding has to accurately reflect that.
That makes so much sense. It's really about capturing the precise clinical picture. Okay, so diagnosis is done. Now let's talk repair. Wound management sounds
Yeah.
involved, like debridement. That's more than just washing it out, right?
Oh, much more. Debridement codes 11,000 through 111047 is the surgical removal of dead, damaged, or infected tissue, non-viable or contaminated stuff. And it's classified really carefully. By the deepest level of tissue, you remove skin, subcutaneous, muscle, even bone, and also by the surface area involved.
Deepest level and area. So cleaning out, say, a diabetic foot ulcer would be coded differently than debriding a burn, depending on how deep and wide the damage is.
Exactly. The depth and the square centimeters matter hugely. There are specific codes for, say, extensive eczematis or infected skin, or for really serious things like necrotizing soft tissue infections in critical areas, genitals, abdominal wall. Those have their own codes.
Necrotizing. Yeah, that sounds serious.
It is. Even removing foreign material from an open fracture site has specific codes. And here's a coding tip. If you're debriding multiple wounds, you only add up the surface areas if they're at the same depth.
Same depth only. What if they're different depths?
Then you'd likely need modifier 59 again to show their distinct sites or depths. It prevents accidentally bundling work that was truly separate.
That level of detail is pretty intense. It really shows the complexity behind what might seem like just cleaning a wound. Okay, so the wound's clean. Now, closing it, I'm guessing it's not always just a simple stitch?
Definitely not. There's a spectrum. We categorize closures into 3 main types based on complexity. First is simple repair.
Okay, simple sounds.
Simple. It generally is. Superficial wounds, epidermis, dermis, maybe subcutaneous tissue, requires just a single layer closure, your basic stitch up for a clean cut.
Got it. One layer.
Then, intermediate repair. This is a step up. It involves layered closure, closing the subcutaneous tissue, and maybe superficial fascia first, then closing the skin.
So closing in layers.
Right. It can also cover single-layer closures if the wound was heavily contaminated and needed a lot of cleaning, or if there was limited undermining.
Undermining. What's that?
That's when the surgeon carefully separates the skin edges from the underlying tissue just a little bit to help them come together without tension. Limited undermining is included in intermediate repair.
Okay, so intermediate is deeper layers, or more cleaning, or a little bit of freeing up the edges. Makes sense. Which leads to complex repair.
Exactly. Complex repair codes 13100 to 13160. This is the most involved. It requires everything an intermediate repair might need, plus at least one specific extra element.
Like what? What makes it complex?
Things like exposure of deeper structures, bone, cartilage, tendon, or a named nerve or vessel, or needing significant debridement of the wound edges, maybe from a traumatic injury, or extensive undermining, freeing up those skin edges for a distance equal to or greater than the wound's width.
So extensive undermining bumps it up to complex.
Correct. Or if the repair involves specific free margin areas, like the rim of the ear, the edge of the lip, the nostril rim, those are tricky areas, or if retention sutures are needed deep down to reduce tension.
Wow, okay. And how do you measure for these? Just add up all the lengths?
Not quite. You measure lengths in centimeters, yes. But they're grouped by anatomical site, like face, trunk, extremities, and by classification, simple, intermediate, complex. You report the total length within each specific group and classification. You don't just add a simple repair on the arm to a complex repair on the face.
Got it. Grouped by location and complexity. That's incredibly precise. It really feels like engineering almost.
Yeah.
But what if you can't just pull the edges together, even with undermining? What if there's a gap?
Right, great question. That's when you move beyond direct closure into reconstruction. This is where adjacent tissue transfer or rearrangement, ATT, comes in. Codes 14,000 to 14302. Here, you're using local skin right next to the defect and moving it to cover the hole. Think techniques like Z-plasty, W-plasty, rotation flaps, advancement flaps.
So you're not just stitching, you're actually redesigning the local skin, sliding or rotating a piece over, like a really skilled tailor patching a hole by strategically moving the surrounding fabric.
That's a perfect analogy, exactly like that. And because it's such an integrated process, removing the lesion and then immediately rebuilding the area with that flap, the initial excision of the lesion is actually bundled into the ATT code.
Bundled again. So you don't code the excision separately if you do an ATT.
Correct. It's considered part of the whole reconstructive effort. And for coding the ATT itself, you measure the size of the original defect plus any additional defect created by designing the flap. You add those areas together.
Okay, primary and secondary defect measurement. That really highlights the artistry and the planning involved. But what if there isn't enough good skin next to the defect, or the defect is just too big? How do you rebuild then?
That's when we get into skin replacement surgery. Codes like 15,002 up to 15278. Often the first step is surgical preparation.
Preparing the wound bed.
Exactly. Getting it clean, healthy, viable, ready to accept a graft or flap. These prep codes are based on location and size, often in square centimeters, or, for babies, percentage of body area. And like debridement, if you prep multiple wounds, you sum the areas only if they're in the same anatomical group.
Okay, prep first, then the actual replacement. You mentioned grafts. I've heard of skin grafts, obviously. But what's this skin cell suspension autograft? That sounds futuristic.
It is pretty amazing. Skin cell suspension autograft, or SCSA codes 15011 to 15018. It's a newer technique. You harvest a very, very small piece of the patient's own healthy skin.
Own skin, so it's an autograft.
Right. Then it's processed with enzymes to break it down into a liquid suspension of individual skin cells. And then this is the cool part, that liquid is sprayed directly onto the prepared wound bed.
Sprayed? Like paint?
Kind of. And the amazing thing is the expansion ratio. You can typically cover an area 80 times larger than the tiny piece of skin you harvested, so maybe a 1.80 expansion.
Wow. That must be incredible for large burns or huge wounds where you don't have much donor skin available.
It's a game changer in those situations, definitely. Now, besides SCSA, we still have traditional autografts. These also use the patient's own skin, split thickness grafts, full thickness grafts, dermal, epidermal.
Okay, the more traditional sheets of skin.
Right, and an important point. If the site where they took the graft from, the donor site, needs its own complex repair, like another graft or a flap, that donor site repair is coded separately.
Ah, okay. Donor site care is separate if complex. Makes sense. What if you can't use the patient's own skin?
Then you might use skin substitute grafts, codes 15271 to 15278. These can be non-autologous human skin, so from another person called a homograft or allograft, or non-human skin, like from a pig, a xenograft, or even synthetic or biological products that act as a scaffold for the patient's own cells to grow into.
Lots of options. And for the substitutes, I assume the material itself is billed separately.
Yes, the supply of the graft material itself is usually reported separately from the procedure code for placing it.
From cell sprays to substitutes. The innovation is just astounding. What about even more complex reconstructions, moving bigger chunks of tissue, maybe with their own blood supply?
Now you're talking about flaps involving skin and potentially deeper tissues. Codes like 15570 to 15738 and others. Flap surgery can be really intricate, sometimes done in stages.
Stages?
Yeah, there might be a stage to form the flap, basically outlining it and maybe lifting it slightly. Sometimes a delay stage where you prepare its blood supply over time before moving it, and then the transfer stage, actually moving it to the recipient site.
Wow. That sounds like a major undertaking.
It can be. And there are different kinds. Island pedicle flaps are moved on their own little stalk containing a named blood vessel. Neurovascular pedicle flaps even include a nerve to potentially restore sensation. Then you have muscle flaps, myocutaneous flaps, muscle and skin, fasciocutaneous flaps, fascia and skin, used for bigger, deeper defects.
So many variations, all depending on the specific need.
Exactly. And related to moving tissue, there's also autologous fat grafting, codes 15771, 15774. This is where fat is harvested using liposuction from one area.
Like the belly or thighs.
Often, yes. And then that fat is processed and carefully injected in small amounts into a defect elsewhere, maybe to fill a contour deformity. The coding is based on the total volume injected per session.
Incredible. It's like sculpting with the body's own materials. Okay, shifting gears slightly. Let's talk targeted treatments, like destruction of lesions. Sounds straightforward, maybe burning or freezing something off. But I bet the coding isn't simple.
You bet right. Destruction, code 17,000-7286, covers getting rid of lesions by, as the codebook says, any method. Could be electrosurgery, cryosurgery, laser, chemicals.
Any method. Okay, so what does matter for coding?
The type of lesion is critical. Is it benign, pre-malignant, like actinic keratoses, those pre-cancerous sunspots? Or is it malignant, actual skin cancer?
Benign versus pre-malignant versus malignant. Big difference.
Huge difference. And how many? Take pre-malignant lesions like those actinic keratoses. Code 17,000 is for the first one you destroy. Then, code 17,003 is an add-on code you use for each additional lesion, from number 2 up to number 14.
Each one from 2 to 14 gets the add-on code.
Yes, but if you destroy 15 or more, then you just use one code, 17,004, which covers 15 or more lesions.
So it's not just counting. It reflects the work one as one, a few more as incremental work, and a whole lot is kind of bundled into one code.
Precisely. That granularity matters. Now, speaking of precision, there's a very specialized technique for skin cancer removal, Mohs micrographic surgery.
Mohs, right. I know that's supposed to be very effective, especially for facial skin cancers.
Extremely effective. Codes 1scene311 to 1scene351. What makes Mohs unique is that the same person is both the surgeon and the pathologist.
Wait, the same doctor does the cutting and looks at it under the microscope right then and there.
Exactly. They remove a layer of tissue, map it meticulously like this corner is 12 o'clock, this edge is 3 o'clock, then divide that layer into sections called tissue blocks, usually up to 5 blocks per layer or stage. They immediately freeze, stain, and examine 100% of the deep and peripheral margins of each block under the microscope.
100% margin check while the patient waits.
Yes. If any cancer cells are seen at a margin, they know exactly where on the map it corresponds to on the patient, and they go back and take just another small piece from that specific spot. They repeat this stage by stage until all margins are clear.
That sounds incredibly precise. Maximum cancer removal, minimum healthy tissue loss.
That's the goal. And the coding reflects this process. There's a code for the first stage, which includes up to 5 blocks, then a different code for each subsequent stage, again, including up to 5 blocks. And if any single stage requires more than 5 blocks to examine fully, there's an additional code, 1scene318, for each block beyond the first 5 in that stage.
Wow. Coding by stage and by number of blocks within a stage.
Exactly. And note, simple repairs after Mohs are coded separately. But the pathology work, the microscopic examination, is bundled into the Mohs codes. It's inherent to the procedure.
A true marriage of surgery and pathology, like you said. Okay, one last area quickly. Breast procedures. Codes 19,000 to 19,499. Similar level of detail here.
Oh, absolutely. It covers everything from simple cis aspirations to more complex things like mastotomy or ductograms. But let's focus on biopsies, specifically the image-guided ones. Codes 19081 to 19086 cover percutaneous biopsies using guidance like stereotactic X-ray, ultrasound, or MRI.
Percutaneous meaning through the skin with a needle?
Correct. And just like with some other procedures we discussed, the imaging guidance and the placement of a localization device, like a tiny clip left behind to mark the spot, are bundled into these biopsy codes.
Bundled again. So guidance and marker placement are included. What if they biopsy multiple spots?
Add-on codes are used for each additional lesion biopsied using the same guidance modality in the same session. And there are specific codes, too, like 19105 for cryosurgical ablation freezing of a benign fibroadenoma, and that code specifically includes the ultrasound guidance needed to do it.
Makes sense. Guidance is integral. But what if they place a marker, say, using image guidance, and then the patient goes for an open surgical excision later? Is the marker placement still bundled?
Ah, good distinction. No. If an open excision, like 19120 and 19126, is performed after a separate session where an image-guided localization device was placed, then you do report the placement code separately in addition to the excision code. The bundling applies when the biopsy itself is done percutaneously with guidance.
Okay, that clarifies the sequence matters. It really shows how technology, like imaging, is just woven into the fabric of these procedures now.
It really is. It streamlines diagnosis and treatment, but demands that same level of precision in coding.
So as we kind of wrap up this deep dive,
Yeah.
it's incredible how detailed this journey through the skin and its procedures really is. From, looking at single cells in an FNA to the sheer artistry of a complex reconstructive flap. Every single step has this precise definition. And you've really shown that this level of detail, this granularity in coding, it isn't just red tape. It's absolutely essential, isn't it?
It truly is. It's vital for accurate patient care, first and foremost, but also for research, for tracking outcomes, for clear communication between doctors, hospitals, payers, everyone. It ensures the specific work done is documented precisely, which affects everything from treatment planning to getting reimbursed correctly to ensuring compliance.
Right. It's the invisible framework supporting the visible results. So next time you maybe look at your own skin, perhaps consider that hidden world just beneath the surface, all that complexity, and think about this silent, intricate language of codes that guides every single incision, every stitch, every biopsy, every act of healing. Makes you wonder, doesn't it? What other layers of coded complexity exist for other systems in the body, just waiting to be understood?